Good morning, everyone, and good afternoon, depending on where you are. Thank you very much for joining us for this webinar. My name is Chip Lyons. I'm the President and CEO of the Elizabeth Glaser Pediatric AIDS Foundation. I want to thank you for taking the time out of very busy schedules for our Evidence to Action webinar, and today on the topic of breaking the mother-to-child transmission plateau. I think many people know, but since the inception of the foundation in 1988, there's been a 95% decline in new pediatric infections, HIV infections in the United States. Globally, new infections have been reduced by more than half since the year 2000. It's remarkable progress. It's not enough progress. That which has been achieved is possible through the hard work of many people, communities, civil society, activists, leaders, governments, funders around the world. And still, it hasn't been enough, particularly as we deal with COVID and the deep disruptions of COVID-19 to HIV diagnosis, care, and treatment services. But even before COVID hit, the pace of the decline in new pediatric infections had slowed in recent years, worryingly so. The global target set for the year 2020, fewer than 20,000 new child HIV infections per year, was missed by a substantial margin. And adolescent uptake of MTCT services continues to be a real concern. We need more. We need flexible approaches, grounded in evidence and tailored to local circumstances as needed. We have the technology to prevent HIV transmission from a mother to her baby. But until every woman has access to and utilizes those services, our work is not done. We also have more tools, diagnostic and treatment tools, better tools than we've ever had. Can we go to the first slide? We have a very impressive, as you can see, group of speakers joining us today. Dorothy Mburi-Ngacha, UNICEF HIV specialist, excuse me. Dr. Vicky Ilunja, EGPAF, DRC. Dr. Lynn Moffinson, Senior HIV Technical Advisor at EGPAF. Dr. Christopher McQuindy with EGPAF in Eswatini. And D. Mpafi, sorry, D. EGPAF Lesotho Youth Advisor with a colleague perspective, also a client perspective on her own PMTCT journey. Next slide. Quickly, before we get into the presentations, just a couple of notes about the call. Obviously, as you're well practiced by now, feel free to ask questions through the Q&A box, and we'll have time to address them at the end. There will also be a recording of the webinar that you can reference or share afterwards. And so with that, I'd like to turn it over to a great colleague and friend, Dorothy. Please go ahead, Dorothy.
Thank you, Chip, and good morning, good evening, or good afternoon, everybody. Chip, you really set the stage nicely by giving us the status of where we are right now. So I'm going to take the next few minutes to really unpack the data and, have a reflection on what it is telling us and what we need to do differently. And next slide, please. So this is where we are at as by 2019. The 2020 data are still cooking and will be available later this year. But as per 2019, 1.3 million pregnant women were living with HIV globally and were able to deliver ART to 85% of these women. Of course, this is commendable, but as Chip has highlighted, is short of our 95% coverage target for 2020. Similarly, the number of children newly infected with HIV at 140,000 is far from the global target of 20,000 infections by 2020. So we need to reflect on why we are missing the mark. Let us interrogate our data further to gain an understanding on why we are not where we should be. Next slide, please. So shown here is the trend in global PMTCT coverage between 2000 and 2019, with dark blue line showing the trends in new infections over the same period of time. What we see is that coverage increased from just 1% in 2000 to the current level of 85%, resulting in a 50% or greater than 50% reduction in new child infections. An important achievement that we need to acknowledge, but still short of where we want to be. You'll also note that during the period between 2004 and 2012 is where we had the most decline and the steepest achievements in terms of increase in coverage. But then after that, we have had slowing down, and in the past 4 years, stagnation of PMTCT coverage and vertical transmission rates. So what we are now referring to as the PMTCT plateau. Next slide, please. So when we zero in on sub-Saharan Africa, which of course is the epicenter of this pandemic, and we look at the data and disaggregate this data by region, we see obvious differences between Eastern Southern Africa and Western Central Africa with clear disparities. While PMTCT ART coverage in Eastern Southern Africa has exceeded 90%, the coverage in Western Central Africa is significantly lower at 59%. When we look at the vertical transmission rates shown by the dotted lines, in both regions, none of the regions have achieved the threshold level of less than 5%. Vertical transmission rates are high at 8% in Eastern Southern Africa and high at 20% in Western Central Africa. This is just a signal to us that our programs are not yet having the full desired impact. Next slide, please. So let's drill down further and look at some country level data. Here, what we're showing is data for 21 PMTCT priority countries in Africa. And what is notable is that 13 of the 21 countries all have vertical transmission rates that are 10% or higher. And you remember the threshold is less than 5%. Additionally, transmission is equally divided between pregnancy and the breastfeeding period. So the blue and the orange are more or less equal. So when we start asking ourselves, what do we need to do differently? This points to the fact that we need to strengthen both our program in the antenatal period, as well as in the postnatal component of our PMTCT programs. Next slide, please. Now, another exciting development in terms of analytics that will help us unpack what's going on and better understand our programs is the stack bar analysis that has been developed by UNAIDS using spectrum modeling, and that tracks the distribution of new infections in children by the underlying cause. So you have a sense of whether the mother got infected during pregnancy, whether the mother got infected during breastfeeding, whether the mother received ART or not, whether she dropped her ART or not, and then correlate that with the childhood infections. So the stack bar on the left shows the details of the missed opportunities for the pregnant woman living with HIV during the pregnancy and the breastfeeding period. And this links to the similarly coded stack bar on the right that shows the number of infant infections occurring in each category of missed opportunity. So, we don't have time to completely unpack the stack bar, but I'd like to highlight 3 crucial points that will help us see where our missed opportunities are, some of them, and also highlight potential game changers in our programs. Firstly, mothers initiating treatment prior to pregnancy, shown in dark blue, are the group that are least likely to have infants who are infected either during pregnancy or in the postnatal period. So we need to be getting our mothers on treatment prior to pregnancy. And that's a challenge to us in our other aspects of our programming. Secondly, mothers who do not receive any ART, shown in the bright yellow, together with women who started ART and dropped off, shown in the gray, contribute the most to new infant infections during pregnancy and the breastfeeding period. So ART access and retaining women on ART are critical in areas that we need to intervene on and strengthen in our programs. And the third group that I'd like to highlight are the women who newly acquire HIV during pregnancy or breastfeeding, shown in the dark orange. And they are the group that are more likely to have infants who are infected with HIV during the breastfeeding period, so postnatal transmission. Next slide, please. The stacks can also, be disaggregated at regional level, and the stacks have helped us to highlight important regional differences in the missed opportunities and underlying causes of new infections in each of the regions. So what we're showing here, side by side, are the stacks overall for Sub-Saharan Africa. That's the first one on your left, followed by the stack on Eastern Southern Africa, and then the one on Western Central Africa. And they show important differences between the two regions. The top line take-home point for Western Central Africa, the one to your far right, is that lack of access to ART in PMTCT is the main contributor to infant infections in programs in Western Central Africa. And so if we're to really break that plateau in that region, we really need to see how to improve delivery of PMTCT, improve access to ART in that region. In Eastern Southern Africa, the bars are a little bit more complex to unpack, but I would say my top line issue relates to incident infections and retention in care. These are contributing significantly to postnatal transmission, which are a high number in this region, and we need to begin to address those. So what we're seeing is that we can no longer have a one-size-fits-all approach to our programming, and emphasizes the needs for us to be more nuanced and to use the data to give us a more differentiated, context-specific response in PMTCT programming. So these stacks are regional stacks, but countries now have similar stack bar analyses available to them through the Spectrum process and through the UNAIDS support. And they can provide critical information to enable decision makers and program implementers to identify what the key gaps in their program are and to inform them on where to target resources in order to achieve maximum impact and reduce new childhood infections. Next slide, please. So in addition to stack bars, we need to use other data available in country, our best available data, to highlight our key programmatic actions. And key questions that we should collectively reflect on as we use our data, the global data, the national data, sub-national data, and site level data, we should be asking ourselves the changes we need to make to our service delivery models to ensure that we are delivering ART to all pregnant women living with HIV during pregnancy. We need to ask ourselves who are missing. Chip earlier alluded to the fact that adolescents aren't doing well in our PMTCT programs. And when they're there, we don't retain them. So why? How can we make our services better reflect the needs of all of our populations? How about the migrants? How about the most marginalized rural populations? So who are missing and why? And then we need to ask ourselves, how can we better support mothers to stay in care and on ART during pregnancy and breastfeeding? And I'm sure we'll have a bit of time to reflect on this. Why are women dropping off treatment? Women who initially accepted the intervention. How can we improve the quality? How can we better support them? I know there are very many important models out there, and we should be able to share those experiences so that programs can actually not only start women on treatment, but also retain them on treatment during pregnancy and through the breastfeeding period. And then thirdly, how can we strengthen primary prevention for pregnant women and their partners? When we started off with PMTCT, we used to talk very articulately about the four-pronged approach. But we have pitched our tent on prong 3, the delivery of ART, and forgotten that we need to also strengthen primary prevention for pregnant women and their partners. And we also need to strengthen prevention in the postnatal period. So what packages do we have in place to support HIV prevention in the context of PMTCT? I know my colleague Lynn Moffinson is going to be talking a lot to some of these issues, and we look forward to her unpacking those for us. Next slide, please. So to summarize, we've seen significant progress, but the progress is uneven. We have hit a plateau in all our regions. And the impact of PMTCT programs is currently insufficient to reach our global targets. So we need to tailor our responses to the context. We need to address the gaps in access, particularly as we see in some regions. And we need to improve the quality of our programs. We need to do better prevention. We need to retain mother-baby pairs across the spectrum of time. And we also need to ensure that they're able to continue with their medications and support them to be able to do that, and the interventions for their infants. We also need to think about comprehensive programming, including HIV prevention and prevention of unintended pregnancies, so that we can actually have a holistic approach to PMTCT, and so that we can break this plateau that we are seeing and be able to reach our targets of ending new pediatric AIDS by 2030. Thank you so much for your attention. Next slide, please. It now gives me great pleasure to introduce my colleague from the Elizabeth Glaser Pediatric AIDS Foundation program in DRC, Dr. Vicky Lunga. Over to you, Vicky.
Thank you. Thank you, Dorothy, for the floor. We are presenting the PMTCT status in the DRC to show the impact of COVID-19 on PMTCT services. To do so, we present the strategy for the elimination of the MTCT and syphilis and the PMTCT cascades in the country in 2019. Then we focus on the impact of COVID-19 on PMTCT services in our 41 PMTCT sites supported. Slide. Thank you. In this slide, you can see that the country has adopted the 5 pillars for the elimination of MTCT and syphilis as follows: the primary prevention of HIV infection, the prevention of unplanned pregnancies in HIV-infected women, the prevention of HIV transmission from infected women to their children, for the treatment, care, and support for HIV-infected women, their children, and also their families. And finally, the strengthening of the health system. So you can see also in the graph beside the projection of the progression of the mother-to-child transmission rate in DRC since 2010 to date, where we are around 15%. Next. So, as you can see for the DRC Cascade in 2019, nearly 4,400,000 pregnant women were received in ANC 1, of which 33% were cancelled and 0.5% were diagnosed positive, while 73 were put in on ARV. Slide. So with regarding the EID, you can see that 88,117 5 women have delivered at the maternity, with 99% of the children exposed, and of which 71% have received ARV prophylaxis, but with the PSR was performed in 83 of these children, of which 6% were positive. Next. So now we'll talk just about the program, the PMTCT program with EGPAF in DRC. Just to let you know that we are supporting around 11 F zone with the following services: to train of maternal and child health services providers, also the HIV testing of pregnant women in ANC and during delivery and so on. So also we are enhancing the mother-baby pair follow-up through mother-mother approach. Slide. So, as I said, now we are just trying to see what was the impact of COVID-19 regarding the PMTCT services. How is COVID-19 affecting this work? As you can see in the slide, we see how COVID-19, which began for our country in March 2020, has negatively impacted pregnant women use of PMTCT services. At the peak between April and June 2020, the number of consultations decreased and then began to gradually increase again. So we think that this can be due to the fact that the population has been adapting to living with the COVID-19. But really, as you can see in the graph, the COVID-19 has really an impact of PMTCT services. Next. So here, on this for COVID-19, it was from October to December, October 2019 to March 2020. And after that, this is the period with the COVID context. What you can see here is the fact that we can also see the difference in PMTCT service used between the pre-COVID period and the COVID period. There is a big difference. You can see somewhere for some indicators, they are decreasing in most of the cases. So the COVID-19 impacted really all our services in PMTCT. Slide. So we can just say something on the challenges we are facing in DRC. The first one is the low viral load and EID coverage, the weak mother-child cohort monitoring, the weak strategic information, the low availability of rapid tests for HIV screening, and the last one is the lost HIV positive pregnant women after HIV testing and before linkage to treatment. Thank you, and over to Dr. Lin, who is the EGPAF Senior Research Advisor and will present the goal innovation turning the tide strengthening community. Thank you for your attention.
Hi, everybody. Next slide, please. So I'm going to talk about global innovation and the 4 prongs of PMTCT. And this is really going to be more future oriented. Some of these innovations are available now. Some of them will hopefully be available in the near future. So first we'll talk a little bit about innovations in PrEP concerning prong 1, primary prevention of HIV. We'll then talk a little bit about contraception in PrEP in terms of prong 2, prevent unintended pregnancies. Innovations in HIV testing and early infant diagnosis for prong 3, prevention of MTCT, and then end with some discussion of innovations in viral load monitoring and treatment for prong 4, care, support, and treatment. Next, please. So first, I'm going to focus on innovations in PrEP and contraception. Next, please. And the first thing I want to discuss is the addition of the Dapivirine ring to the prevention toolbox. So the Dapivirine ring is a female-initiated option to reduce the risk of HIV infection. So the ring is worn in the vagina for 28 days, after which it's replaced by a new ring, although new data from the HIV for Prevention meeting suggested that this may even be able to be increased to an every 2-month interval. And it's made of silicone, easy to bend and insert, and it works by releasing the antiretroviral drug Dapivirine from the ring into the vagina slowly over 28 days. Next, please. So there have been 2 randomized trials, the MTN Aspire trial and the Ring trial, that have demonstrated that the ring is effective in reducing the risk of acquiring HIV infection. So in these initial randomized trials, overall, the ring was about 30% effective in reducing HIV. However, for the most consistent users, efficacy was as high as 75%. There were no differences between treatment and placebo arms in terms of pregnancy outcomes, fetal or infant outcomes, but the number of pregnancies were small in the study. And more recently published is open label extensions for the MTN called Hope and for the Ring called Dream, where they're having visits every 3 months. And they have found, they published in Lancet HIV shown above, increased efficacy, increased adherence, and increased retention, with the Dream extension indicating a 62% reduction in HIV transmission. And so the ring, it acts locally, systemic absorption is low, and research on values and preferences indicated that ring use was considered highly acceptable both by the woman and her partner. Next, please. So there are several ongoing studies to allow the ring to be expanded to additional populations. The first is the REACH study, which is specifically looking at the safety and use of the ring in adolescent girls and young women aged 16 to 21. The DELIVER study is looking at the safety of the Dapivirine ring and oral PrEP in pregnant women. And then finally, the Be Protected study is looking at the safety of the ring in breastfeeding women. So we will soon have data for these populations. Next, please. And so in the March 2021 guidelines from WHO, the Dapivirine ring is now recommended. And the recommendation says the Dapivirine vaginal ring may be offered as an additional prevention choice for women at substantial risk of HIV as part of combination prevention approaches. Next, please. And in addition to the ring, data from the HIV Research for Prevention meeting just 2 months ago demonstrated phase 1 PK studies indicating that formulations have been made that now can allow both HIV prevention and long-acting reversible contraception. And so the data was presented on the 90-day Dapivirine ring plus levonorgestrel vaginal ring to provide contraception, as well as tenofovir. And so this would allow both prevention of pregnancy and HIV at the same time. So this is very exciting and hopefully will be in the very near future. Next, please. I now want to talk about long-acting cabotegravir. At the HIV Research for Prevention meeting, the results of HPTN 084 were presented. Next, please. So cabotegravir is an integrase inhibitor with a very long half-life. It has a half-life of 40 hours orally, 40 days as a long-acting nanosuspension. And it was recently approved for treatment of HIV when combined with rilpivirine in the US, given monthly IM. But here it was being evaluated for prevention as a single drug, and it was compared with oral daily tenofovir FTC. Just a comment that there is a long tail of cabotegravir post-injection with levels persisting as long as 12 months. So in the HPTN 084 study, over 3,200 women were randomized to either cabotegravir in blue or tenofovir FTC in kind of orange. There was an initial 5-week oral phase where you got the active agent cabotegravir orally or placebo, or tenofovir placebo or active tenofovir, depending on the arm. And then there was injections every 8 weeks, either cabotegravir active or placebo, plus an oral tablet, either placebo or tenofovir FTC active, and that was given for up to 3.5 years. And then there was an open label period of 48 weeks when the injections were stopped and everyone just got oral tenofovir. Next, please. So cabotegravir was found to be significantly superior to oral daily TDF FTC. So HIV incidence in this study was 40 infections over 3,800 person years, with a pooled HIV incidence of 1.03 per 100 person years. There were 4 infections in the cabotegravir group compared to 36 in the tenofovir FTC group, for an HIV incidence of 0.2 versus 1.86. And just a comment that the incidence without PrEP in the TDF2 study in Botswana was 3.1 per 100 patient years. So the incidence seen with the tenofovir FTC in this study, 1.86, is already 60% lower than with no PrEP. And you can see in the Kaplan-Meier curve below that compared to the tenofovir FTC, which is already 60% lower, there was an 89% further reduction in HIV incidence with cabotegravir in blue compared to tenofovir FTC in orange. Next, please. Adherence to cabotegravir was superior to tenofovir FTC, and this probably accounts for the tremendous efficacy. And you can see in this graph over time that injection coverage was over 90% without change over time for the cabotegravir arm. And below you see the tenofovir plasma concentrations in the tenofovir arm, with the light pink being detectable TDF and the darker pink showing you daily use, a level of greater than 40 nanograms per ml, consistent with taking it every day. And you can see that only 62% overall had tenofovir detected, and only 46% had levels consistent with daily dosing. And you can also see there was decreased adherence over time. And this is pretty typical of what we see in many of the PrEP studies. Next, please. The safety of cabotegravir was good. The top graph shows you injection site reactions, comparing the cabotegravir in blue to the tenofovir FTC placebo injections in pink. Now, injection site reactions, with cabotegravir were more frequent than with tenofovir FTC placebo injections, but they were generally mild, primarily seen with the first injection, and not associated with any discontinuations. In the bottom graph, you see the changes in weight by arm with cabotegravir in blue and the TDF FTC in orange. So the cabotegravir recipients had a greater increase in weight than tenofovir FTC, but both groups gained weight over time, and the overall difference was only 0.2 kilograms per year. So this was not the alarming huge increase in weight seen in some of the dolutegravir studies in South Africa. Next, please. This slide looks at cabotegravir in pregnancy. Now, long-acting contraception was required for the study, but despite that, 50 pregnancies occurred, and you can see 29 in the cabotegravir, 21 in the tenofovir FTC. And then in the bottom, you can see pregnancy outcomes. A number of pregnancies were still ongoing. Each had 10 live births. The rate of pregnancy loss was similar, 4 and 3. And the rate of birth defects was low, with no neural tube defects observed. So there was no obvious difference between cabotegravir and TDF in live births or pregnancy loss in the few pregnancies that occurred in the study. Next, please. So what's going on now? So the study HPTN-084 was in, of course, adults over 18. So HPTN-084-1, called LIFT, is evaluating the safety, tolerability, and acceptability of cabotegravir in cisgender female adolescents less than 18 years, and they have a similar study for MSM and transgender female adolescents. So this drug still needs to undergo regulatory approval. So it's too early to know now when it will be available for individuals outside of trials. And unfortunately, there's little data in pregnancy and breastfeeding. And some recent interesting in vitro data suggests that the transplacental transfer of cabotegravir to the fetus is much lower than dolutegravir. So it's possibly much less fetal exposure to drug. Next, please. So we need to begin now to plan for programs implementing this highly effective and attractive prevention intervention for women. Doesn't require daily adherence to a pill. It does require injection, but qualitative studies indicate that this was highly acceptable by both women and men. It will require sterile injection procedures at a facility. And the long tail does raise the issue that if you stop cabotegravir PrEP and you become infected during this tail, that you may develop integrase-resistant infection. And so there may be a need to cover the tail in people who stop with oral PrEP. And guidelines clearly will need to address use in pregnancy and breastfeeding. And my hope is that it will not be prohibitive and that it will allow use in pregnancy and breastfeeding. And of course, it's going to be important to monitor implementation effectiveness. Next, please. So I want to talk very briefly about other new long-acting antiretroviral drugs that are being considered for PrEP that will be available within the next couple of years. The first is Islatravir, which is a translocation inhibitor, and the second is Lenacapavir, which is a capsid formation inhibitor. Next, please. So Islatravir is a very exciting drug. It's the first in class reverse transcriptase translocation inhibitor, NRTTI, and it's highly potent against resistant virus. It's rapidly converted to the active triphosphate within target cells, and there it inhibits reverse transcription by multiple mechanisms of action, not just delayed chain termination. It has a very long half-life, 190 hours in PBMC, which means that it could be given orally once a month with an appropriate dose. And a phase 2 evaluation was presented at the HIV Research for Prevention meeting. And excitingly, it is also being evaluated as a once-a-year subdermal implant with the potential to be combined with a contraceptive. Next, please. So that's a very exciting drug, and that one is in near development. This one is even more exciting. Lenacapavir is a new drug. It's a first-in-class capsid inhibitor with multiple areas of action, both capsid disassembly and nuclear transport, virus production, and capsid assembly. They're all inhibited. Very potent antiretroviral activity, 2 to 3 log decrease over 10 days, and high potency against resistant virus. And most exciting here is that a sustained delivery formulation given subcutaneously supports once every 6-month dosing. And a 900 milligram dose subcutaneous was shown to maintain target drug levels for 26 weeks. And there are now plans to study this in adolescent girls for PrEP, given subcutaneously every 6 months, in comparison with daily oral TAF FTC or TDF FTC. So Gilead was running a study for adolescents comparing TAF and TDF, and they have now added Lenacapavir with placebo to these studies. And this study will be very important in the next couple of years for a new prevention intervention. Next, please. Briefly, I want to talk about the use of long-acting broadly neutralizing antibodies, primarily VRC01. So broadly neutralizing antibodies are available against different parts of the envelope. VRC01 is one of the first evaluated in humans. They have a continuum of potency and a breadth of coverage of viral strains, and more potent antibodies have now been developed. Next, please. So the AMP trial was presented at the HIV for Prevention meeting, and this is broadly neutralizing antibody using VRC01. Infusions were given every 2 months for 10 infusions to HIV uninfected persons, and new infections assessed through week 80. And this was a proof of concept study. Next, please. So efficacy depended on virus antibody sensitivity. And although it was thought that most circulating virus would be sensitive, it turned out that only 30% of circulating virus was sensitive. However, in the 30% of cases where people were exposed to VRC01 sensitive strains, and that is strains with an IC80 of less than 1 micrograms per ml, and that's in that little blue line shown up there, the rate of acquisition of HIV was decreased by 75% to 0.2 per 100 person years with VRC01 compared to 0.86 per 100 person years with placebo. And this now has established a biomarker for prevention. And combination broadly neutralizing antibodies will now be studied to cover more strains to be evaluated in the future and are quite promising. Next, please. Potentially even more exciting, however, is the use of long-acting broadly neutralizing antibodies for infant prophylaxis for prevention of breast milk transmission. And we know that there's residual breast milk transmission despite maternal treatment, and that postpartum viral rebound is common. And there's been recent interest from both WHO, IAVI, and USAID, and we already have data in neonates on several of these antibodies. Already published is VRC01, broad, potent, safe in neonates, half-life of 20 days, given monthly. VRC01-LS, which is longer acting, again, shown to be safe, half-life of 60 days, every 3-month dosing. And then at the HIV for Prevention meeting, VRC07-523-LS, 5 times more potent than VRC01, was also shown to be safe in neonates and be able to be given for every 3-month dosing. So this may be an important adjuvant to maternal treatment in the future for prevention of breastfeeding transmission. Next, please. So now I want to move and end with innovations in testing, EID, and treatment. Next, please. So HIV self-testing in pregnant and postpartum women. We know that in order to detect incident HIV during breastfeeding in particular, you need to do repeated testing. And in 2019, WHO has already recommended that HIV self-testing should be offered as an additional approach to HIV testing. Next, please. So could HIV self-testing be a strategy to increase repeat testing among pregnant and postpartum women? And there was a recent pilot mixed method study that was published in 400 pregnant and postpartum women in 3 facilities in Kenya, where they could choose between an oral self-test in the clinic and a standard finger prick. About 50% chose both. And the chart shows you experience with choice. And I bring people's attention to the fact that oral self-testing was viewed as not painful by almost 100%, fast and easy to conduct. And many of the women said that they would use it in the future, and almost 95% would recommend this to others. So this is a promising intervention that could be implemented even now. Next, please. Point of care testing for early infant diagnosis and maternal viral load monitoring provide us with easier and more timely testing, leading to more timely treatment start and modification. Next, please. So WHO recently conducted a systematic review and meta-analysis showing that infants are 8 times more likely to start treatment within 60 days with point of care compared to standard of care. And I refer you to the Bianchi paper that comes from the large study that EGPAF did. So 92.8% started within 60 days with point of care compared to 50.5% with standard of care. Time to ART initiation, 0 days for point of care compared to almost 40 days with standard of care. And same day treatment initiation in infants, 51% with point of care versus 0% with standard of care. Next, please. Additionally, WHO did a systematic review of point of care viral load testing, showing that turnaround time and clinical action on elevated viral loads significantly improved with point of care. It improved turnaround time of the results to the clinician, improved turnaround time of the results to patients, increased the probability of same day results to the patients, increased the probability of and reduced time to differentiated care, and increased retention in care, and most importantly, in viral suppression at 18 months. And also, I point out, it reduced the time to clinical action for an elevated viral load. Next, please. So based on these data in March 2021, point of care testing is recommended. It said it should be used to diagnose HIV among infants and children younger than 18 months of age. So point of care should now be standard of care. And point of care viral load may now be used to monitor treatment among people living with HIV receiving treatment. So these are important new recommendations. Next, please. And I want to end with innovations in treatment. And we have the ability to improve and simplify treatment, which could enhance adherence, alleviate postpartum rebound, and reduce breast milk transmission. And there are a number of long-acting antiretroviral drug regimens under evaluation. As I already pointed out, monthly carbotegravir rilpivirine is already approved in the US, and I think is a very promising alternative to be implemented in lower resource settings. And right now we have an every 6-month injectable subcutaneous Islatravir Lenacapavir regimen that is under development and will be under study. And there are already new, simple, potentially less toxic dual drug combinations, in addition to dolutegravir 3TC, a once daily fixed dose combination of Dapivirine and Islatravir was shown to be equivalent to a triple drug regimen in phase 2 studies, and a once weekly oral new NNRTI with Islatravir is also under study. Next, please. And the last thing I want to point out is exciting innovations in novel delivery methods that do not require oral daily dosing administration and can increase privacy about taking treatment and enhance adherence. And one of the ones I thought was most exciting was an intradermal microarray patch. And so these patches contain hundreds of little projections that deliver the drugs into the skin. You apply it to the skin, these projections dissolve to release the active drug, and then the patch can be removed. So you just put a patch on your skin. And the other is implantable drug delivery systems that are already under study for cabotegravir and some of the other drugs. And this is like oral, like contraceptives, and could be taken once a month, once every 6 months, or as we talked about with Islatravir, once a year. Next, please. So I hope I've shown you that there are many innovations. Some of them are existing now. Some will be available, I think, in the near future that can help us get to elimination of new pediatric infections. Next, please. Okay, I'd now like to move to Christopher, who's going to talk about learnings from Eswatini. Thank you.
Thank you, Lynn. Good morning, good afternoon, everyone. I will take you through the Eswatini experiences, focusing more on the lessons learned. And I'll start with just a brief background to look at the HIV situation in Eswatini. Our PMTCT coverage is initially covered by Dorothy. We also look at the MTCT rates, our path to elimination, and also now then to look at the interventions. Well, I will just focus at one intervention per prong. So Eswatini is formerly Swaziland, is a small country in Southern Africa with a population of about 1.2 million. And of note is 52% of the population is under 20. We're a country with a high burden of HIV, with about 200,000 people living with HIV, and 5% of that children are 0 to 14. And with our adult population, adult population 15 to 49, the prevalence is around 27%, and much slightly lower in men at 18.9, and females at 34.3. And for pregnant women, the prevalence rate is around 34.5. Next slide. So when you look at our coverage, starting from 2015, we have scaled up, over the years. And as of 2018, we've started seeing coverage above 95%. And also that has reflected on our MTCT rates, where we have seen that gradual decline. And in 2009, we're around 8%. And as of 2020, we're at 0.8%, looking at the MTCT rate at 6 to 8 weeks. Then looking at the 18 to 24 months, we have a study, although it's a bit on the older side, done in 2016, published in 2018. The MTCT rate at the end of breastfeeding was around 3.6. Next slide. So when we look at our PMTCT cascade, we are noting that of all new ANC clients, around 27% come with a non-HIV status. And after testing, we see that ANC remains one of the high-yield units. And also what we are seeing is that testing, in terms of testing, we are around 100%. And for those identified positive, including those who are coming with a non-status, not on ART, we are initiating around 99%. Next slide. So as Eswatini, we are also on the path to elimination of mother-to-child transmission. And this started around 2017 with a selection of the National Validation Committee. We have engaged the consultants, for the trainings and also to conduct the baseline or the mock assessment that was conducted in 2018. And we are currently implementing interventions to address the gaps identified from the baseline assessment. So as Eswatini, we noted from the baseline that our case rate is still very high at 1,193 and 1,103 per 100,000 population in 2017 and 2016 respectively. And that also means we are still above the case rate for the target for gold, silver, or bronze. And also from the baseline, we have noted the paucity of population level data on MTCT rates. And as a recommendation, we are working on, we are conducting an evaluation to determine the MTCT rates in Eswatini. And currently, we are still, the study, the evaluation is still ongoing, and I will share the results soon. Next slide. So looking at the first prong, I'll talk to the PrEP among pregnant and breastfeeding women. So in Eswatini, EGPAF is the PEPFAR lead for PrEP services. And as a COP19 priority, we worked on scaling up PrEP for pregnant and lactating women. So the approach that we used the opt-out approach for all HIV negative pregnant and lactating women would offer them PrEP. And over the year, over the months of last year, from January to December, is shown by that graph. We have seen that steady increase in the proportion of pregnant and breastfeeding women initiated or enrolled on PrEP to all the individuals enrolled on PrEP. So as by January, we are around 9% for pregnant women. And by end of December, we're at 37%. And also 13% for those breastfeeding. And also among all new ANC clients, we are also seeing an increase in the number enrolled. And also in the same period, we noted about 20% of women, of the pregnant women were enrolled on PrEP. And we are also noting that some of the lessons, just having a clear documented advanced rollout strategy facilitates that smooth scale up. Next slide. So moving on to the second prong, I'll talk about family planning, ART integration. So in all the supported sites by end of 2020, as EGPAF, we supported all the sites to integrate. So I can say by end of year, all sites had integrated FP services into the existing care and treatment services. And some of the services that we talk to is the assessment for voluntary FP needs, provision of FP counseling, and provision of the services, and where needed, referral in accordance with the national guidelines, and also just ensuring that smaller facilities refer to the bigger facilities as needed. So mostly our support has been through mentorship and trainings. And we have seen that an increase in the number of patients receiving the long-acting contraception over the years, starting from 2014 to date. And looking at our cascade, we are seeing that for all women who are coming to the care and treatment platform, we had about 50,417 in a year. And of those, 77% came with an already known status. And for those who were eligible for testing, 99.8% were tested. And those eligible for ART, 80% were initiated. Still on the low side, but we have interventions to address that gap. Next slide. Then on the third prong, we talk to the mother-baby pair follow-up for retention through the use of community focal mothers. So EGPAF piloted a community-based follow-up of mother-baby pairs, recruiting from the facility and following them up at community level, doing the proactive follow-up, reminding them about the visits, and ensuring that they get all the services as needed, and also strengthening the bi-directional referrals from community and facility to community and community to facility. And what we noted is that there was an improvement in the number of children who were accessing child welfare services that include immunization, and that was kept at 100%. And as you can see in that graph on the baseline, the number of children who completed child welfare visits by 18-24 months were at 36%, 12% respectively. But now with the initiative, we started seeing all women retain, all children are coming for the services as needed. And we've also seen extra benefits for the mother, where mothers were also able to access their MCA services, including ART services, viral load. And the initiative after the pilot has been scaled up to national level and adopted under the Global Fund with community mental mothers in all constituencies in the country. And this initiative has also been rolled out in other countries and accepted as a PEPFAR solution. Next slide. So on the fourth prong, we did MTCT audits MTCT audits to characterize all identified HIV-infected infants. So what we did was the aim was to identify the possible factors associated with MTCT during ANC labor and delivery and PNC up to 24 months. So through the technical working groups, the core group developed the tool to identify maternal factor, or to identify possible factors, and also the timing for mother to child transmission. And what you have seen is there were 23 children who were infected in the whole country, and 11 of them were infected, and the children were diagnosed at 6 to 8 weeks, and the 12 they were then diagnosed during the postnatal care period. And what we noted is that three of the mothers were HIV negative at the first ANC, meaning that they're seroconverted, and that this further emphasized the need for PrEP during pregnancy. And 3 were positive and not on ART. This also talked to now ensuring that all positive women should be initiated on ART. And also we had 5 women were positive and on ART. This could also talk to issues around adherence. So we also characterized those women whose children were positive during PNC. And we also noted that 5 of them were negative at first PNC, and 6 were positive and also on ART, but their children got infected. So as Eswatini, the program is planned now to engage the surveillance unit to consider now formalizing this tool to be part of the ongoing MTCT surveillance. Next slide. So at this point, that's the end of my presentation. I will introduce Dee Mpafi, a colleague from Lesotho, a youth advisor. She'll take us through the PMTCT journey from a client perspective. Over to you, Dee.
Thank you so much, Christopher. Good morning, good afternoon, everybody. My name is Dee Mpafi. Like Christopher said, I'm a senior youth ambassador in EGPAF Lesotho and a youth advisor. So I'm going to talk on a client side of me. I tested for HIV back in 2016 and I was diagnosed positive. I got into the immediate test and treat, and then took my medication from then. It was such a drastic moment, and I got depressed. because of the stigma and discrimination that I faced. And I was then linked with the Adolescent Corner in 2017. That's where I got all the psychological support that I needed. I had also support from my family. I had support from my boyfriend, who was negative when we tested positive. And then from then, now I have a baby who will be turning 8 months on Friday, who is HIV negative, and I am positive and undetectable. So what happened was I got pregnant in 2019, late December, and then I received the ANC services from Quintu, which was where I'm taking my medication, my ART medication. And then I've been on the PMTCT services there, same as my baby, who was given the NVP prophylaxis immediately when she was born. I had a natural birth. From there, my baby took the CTX prophylaxis when she was six weeks after testing for HIV, and the results were negative. Her results came out after 2 weeks, which was very traumatizing for me, because as much as I'm undetectable and I know I'm taking my treatment well, it's really still scary and terrifying knowing that you have someone's life in your hands, and knowing that anything is possible, and the results are very unpredictable. It took me 2 weeks to wait for that, and I got my baby negative, which is very great. So now that I've received the PMT services, I do recommend other young mothers and our adolescents that, as much as we know that it's not as easy as we think it is to plan pregnancy, because we do advocate for contraceptives and all the injectables and stuff, but for young people, it's not as easy to be open, accepting them, especially when there are so many myths that comes with contraception. So when one finds out that she is pregnant, must by all means go to the facility and make sure that they are on treatment well, they test their viral loads and make sure that they are undetectable. So one other thing that I would recommend that we improve in the health services is that, as much as my baby tested negative when she was 6 weeks old, and now she's still breastfeeding, it's kind of hectic to not know what is happening during the course of the months waiting for the 9th month test. And now that she is on mixed feeding, it's really not sitting me well, or us as a family well, that we have to wait for that much to know how the result has been, especially for me, who I tested negative 3 months later and then I was positive. So it's really not settling with me well. But really, it's been a great experience, and now I can advocate more on young people living positively. I have a negative husband, I have a negative baby, I'm positive, and I'm still on my ART, on DTG for that matter, and my viral load is still lower than detectable. And I would like to point out something that I'm very happy with, that Dr. Lin was talking about, the 6-month injectable SQ for breastfeeding transmission prevention. I think it's a very brilliant idea, because now that my baby's taking the CTX for prevention, because she's still on breast milk, it's really, I don't know, it's like she's kind of having a fatigue, I guess. She does not want the taste of the medicine. So it's really annoying for her to give her medicine every day when I can have the injectable that she will take like for 6 months and stuff. So anyway, my experience with PMTCT is pretty good, and I really do advocate for more of that, and especially having adolescent corners, scaling up adolescent corners will really help, because now we'll be sitting there as young people, young mothers, sharing what we are going through, sharing the experiences and sharing how we can take care of our babies. As much as we have the nurses and the mentor mothers giving us all the education on PMTCT, it's pretty much great when you have another young mother who is pregnant as well, telling you that, no, I'm on medication, so you can do it as well, for especially those who are testing positive when they are already pregnant. So thank you very much.
Thank you very much to all the presenters. This is Laura Gay, Vice President for Research. And thank you all for the active participation during the Q&A. I think several of the questions have been answered, but there's a few that are remaining that we would like to present, to have the presenters answer. I realize that there's only about 2 minutes left before the end. So for those of you who can, you're welcome to stay on for another 5 or 6 more minutes so that we can answer a few of the questions. So I want to add my thanks to everybody for the very informative presentations and a lot of the very good questions that have been coming through on the Q&A. So maybe I'd like to start. There was questions around the Mentor Mothers program or peer support in the challenge with retaining and keeping women in care throughout the pregnancy and breastfeeding period. I know both Christopher mentioned it as well as Vicky, but this was targeted to Vicky to really assess the contribution of that. And is that, what is it, how is it working? And are there ways that we could do more to utilize this important resource?
Thank you for the floor. So just to say that Mentor Mothers, they are playing a big role in the program. I would just like to share some roles. The first one is the fact that they are in the support group, where they are facilitating discussion with other mothers, and also they are giving the counseling. You know, in some facilities, providers doesn't have time to do everything. So they are helping providers to facilitate counseling. Also, they are playing the role in the interpersonal communication. But one of the big thing, or the big role they are playing, is to provide the psychosocial support to their peer. And also, you know, they are also referring PMTCT client to other services in the facilities. So also, there is a role in tracking, in the active tracking of those who are missing PMTCT appointment. But we can just say the choice for Mentor Mother, there are a certain number of, because they need some skills to be able to conduct other. So this is maybe what I can summarize related to the role from Mentor Mothers. Thank you for the floor, Laura.
Thank you, Vicky. And I just want to remind people, or let people know, that if your question doesn't get answered, we have the chat, the questions in the Q&A, and you can always follow up with publications at pdaids.org to get follow-up after the presentation if you have to leave or we don't get to your question. Thanks. Another important question that I think maybe Dorothy, you could start, and then we could go to Lynn, is about, given that we've seen the numbers of infections that occurred during the postnatal period during breastfeeding, In terms of the guidelines for WHO and the recommendations for how often during the pregnancy or the postpartum period repeat testing should be done, that there's inconsistent countrywide plans in terms of how frequently to do the testing. And then secondly, how well does self-testing in that period work, either individually or guided by the healthcare workers. It's also tied to the question about if a woman is breastfeeding and is undetectable, is she still able to pass on the infection to their child? So maybe Dorothy, if you could answer about the frequency and self-testing and recommendations, and then we can go to Lynn to the other questions.
Thanks, Laura. I mean, the frequency of testing, or repeat testing has been articulated by WHO based on the background HIV prevalence, the setting. So that if you're in a setting of high HIV prevalence, then WHO has articulated that you should be having repeat testing like every 3 months throughout the breastfeeding period. Now, how countries have rolled this out has been a challenge. And I think part of what is making it a challenging recommendation to roll out is the availability of test kits and the cost of test kits and the prioritization of test kits for the antenatal period rather than for the postnatal period. So there are guidelines by WHO, and particularly in settings where prevalence is higher than 3%, there is that recommendation for repeated testing. But the question is now, how do you prioritize your tests in a situation where you have limited number of tests? I hope that answers that.
So thanks, Dorothy.
Sorry, I'm not completely sure, Laura. I was just going to say that in thinking about this talk today, I thought that self-testing provided a very interesting way to be able to provide to women the tests for them to do themselves, knowing how important it was, but not requiring them to necessarily come back into the clinic. So that's why I presented that recommendation. I thought that it was a very interesting way to be able to evaluate and do repeat testing. Now, it hasn't actually been implemented. All I could find was this mixed method study where it seemed highly acceptable.
And that's an important question then to add into the programs as it's starting to be rolled out, that we are collecting the evidence to inform that answer.
Yes.
And Lynn, could you ask about if a woman is breastfeeding and is undetectable, the risk to the child? And then also there were some questions about self-injectable ARTs for PrEP and resistance issues around the use of PrEP.
In terms of
injectable PrEP, sorry.
Yes, yeah. So the first question was on women who are undetectable. So can we definitively say that if you are undetectable, that you don't have any risk of breastfeeding transmission? And the answer here is no. There are a few limited situations in which viral load was measured and was less than 50, but transmission still occurred. Now, in a number of those cases, there was rebound before and then they came down. And so by the time the infant was tested, maybe they were undetectable, but 5 weeks before they weren't. I think we can say pretty definitively that undetectable equals untransmittable for peripartum infection in women who are on antiretroviral drugs before they become pregnant, are undetectable before they become pregnant and during pregnancy through delivery, that those women do not appear to transmit in utero or intrapartum to their infant. However, I don't think we can say U equals U definitively for breastfeeding. It may be that if you are undetectable before pregnancy, stay undetectable throughout pregnancy, delivery, and breastfeeding, that may be the situation where undetectable equals untransmittable, but right now we don't have the information to say that. But we can say that transmission risk is extremely low in those situations, less than 1%. The other questions, one was risk of resistance with PrEP regimens. So most of the time when you get infection in people on PrEP, it's because they stopped taking PrEP and therefore the drug isn't on board, so they don't get resistance. Now with carbotegravir, with that long tail, there is some concern that if infection occurs, that resistance might occur. I don't think they've done those studies yet in the HPTN 084 study. In that study, there were only 4 infections. 1 infection occurred during that oral transition time, so very early on. 2 infections occurred in people who stopped their injections, and only 1 occurred in a person who was still taking injections. So the risk of infection is very low, and we still need data to know whether if you get infected during that tail, that is a risk of resistance and whether you need to cover that with something like oral tenofovir. And Catherine asked, are there any self-injectable ARVs for PrEP? So no right now, but that's a very interesting question, particularly if you can give an injection subcutaneously, like with Lenacapavir, that potentially could be looked at as a self-injectable. But I think the more exciting things might be the depot things, like where you could use a small depot of the drug that can last for a year and gets changed once a year. I think that was
Thanks.
the questions.
Yep.
Yeah.
Yes, thanks very much. And I appreciate all of the comments and the questions. I think we've gone through most of them and we're certainly over time. So again, I would like to take the opportunity to thank all of the presenters with a wide variety of insight. Thank you, Dee, for your extremely wise words of wisdom and sharing your experience. And I think the youth and women of Lesotho certainly will benefit from all that you contribute to them. So we appreciate all that you do for the youth and women in Lesotho and beyond. Again, thank you for the active questions. And if there's any questions you have, please follow up and we will make sure that we get back the information to you, and the presentation will also be shared. So thank you very much for your active attendance and have a great day or evening.